This module is on feeding tubes, and I am Jean Howell, and I will be your facilitator for this learning. The objectives will be to understand the purpose of various types of feeding tubes, to list 3 problems that can occur with a feeding tube, and to state the importance of oral hygiene with tube feedings, and last, to demonstrate the skills necessary to safely administer tube feedings and care for the site. The state of being fed by a feeding tube is called gavage or enteral feeding. Gavage means feeding with a stomach tube or with the tube passed through the nares, the pharynx, and the esophagus into the stomach. Enteral means within or by way of the intestines. A feeding tube is used to help deliver nutrients to a person's body when they cannot take food in through their mouth. There are a number of reasons that a feeding tube might be needed, which range from an inability to take in and chew food due to weakness or lack of consciousness, to risks of choking and blockage or injury to the upper digestive system. A feeding tube is not always a permanent fixture, and it may be used for both short-term and long-term uses. There are a few kinds of feeding tube, and they are differentiated by their placement. Feeding tubes are usually made of a polyurethane or a silicone. The diameter of a feeding tube is measured in French units, and each French unit equals 0.33 millimeters. The size of the tube and the type is ordered by the physician. They are classified by site of insertion and their intended use. A feeding tube must be cared for, and the spot where it is placed is prone to infection and irritation. One type of feeding tube is the G-tube. The G-tube is also known as a gastric feeding tube or a PEG tube, and the PEG stands for percutaneous endoscopic gastrostomy. It's sometimes also referred to as a mushroom or a button tube. Percutaneous simply means that it is delivered through the skin. The endoscopic is looking through a tube and a scope to observe what's inside of a hollow organ or a cavity. And the gastrostomy refers to a surgical incision into the stomach. The G-tube is connected directly to the patient's stomach through a small incision made in the abdominal wall structure. It is about a 20-minute procedure where the patient is sedated. The tube is kept within the stomach either by a balloon on its tip, which can be deflated, or by something like a retention dome, which is wider than the tract of the tube. This kind of feeding tube is designed for long-term tube feeding, and its placement is generally on the left-hand side of the abdominal cavity, slightly below the ribs. A G-tube can be useful when there is difficulty swallowing due to a neurologic condition such as a stroke, or there is an anatomic disorder such as atresia, which is simply the narrowing of the esophagus. Gastric leakage can occur, irritating or even eroding the skin around the insertion site, which we call the stoma. Therefore, because that leakage is possible, proper and frequent cleaning or using a barrier cream and dressings can minimize the irritation to the skin. Due to dysphagia, a person with tube feedings will also be at a risk for aspiration pneumonia from regurgitating the formula that is fed to him. A second type of tube is the J-tube, also known as a jejunostomy tube or a PEJ tube. And this is another kind of feeding tube. Like the G-tube, this tube is placed surgically by making a small incision in the abdominal wall. However, the J-tube is connected directly into the jejunum, and nutrients completely bypass the stomach with this type of tube feeding. Usually the tube is placed toward the center of the abdomen and connected to the upper portion of the small intestine. Sutures are sometimes used to hold the tube in place, and a feeding pump which pumps a predetermined amount of nutrient mix into the tube must be used with this kind of tube feeding setup. A third type of tube is the NG tube or nasogastric tube, and this is placed into the nostril of the patient. The tubes used for NG tubes are smaller than the tubes used in surgical placements, and they run through the nose, down the esophagus, directly into the stomach. The tube's placement must be checked and adjusted before each feeding, and surgical tape is often used to secure the tube to the nose. The NG tubes are rarely used in nursing homes today due to the fact that the tube can move, and there's always the risk that contents from the stomach can be aspirated and go into the lungs. Regardless of the type of tube, the liquid nutrition is usually referred to as a formula. The formula is chosen by a dietitian based on the client's condition, the nutritional needs, the caloric needs, and the location and type of tube that is being used. Although rare, some clients may have a fully functioning gastric system, but if they have a condition that affects their ability to take in the right nutrients, they need a formula supplement. In these cases, the client is physically able to drink their nutrition. However, unlike supplements like Ensure that are very nutritious and flavored nicely, some specialty formulas are not and can be very unpalatable. In these cases, the client may eat normally and have a G-tube for getting the formula. This is commonly seen with children with extreme food allergies. There are two types of tube feedings, intermittent and continuous. With an intermittent, this is most similar to eating a periodic meal. It would be like receiving a dose, then waiting a certain number of hours and taking another dose. And intermittent feeding is usually delivered by filling a large syringe or container hooked up to the tube and just letting the formula drain in over a short period of time. This is the bolus or gravity feeding system. If the feeding is going to take longer than about 30 minutes, the client may find it more beneficial to use a pump that can control the rate of delivery and allow the person or the caregiver the opportunity to be other things during the delivery. Continuous feeding is just that, continuous over long periods of time. 8 to 24 hours is very common. Continuous feedings almost always require a pump, especially if the client is able to get around on their own, are active, or have an active caregiver. Continuous feeds that do not require a pump are for patients that are not active or are bedridden, possibly in a nursing home. These patients receive their nutrition by gravity and a roller clamp on the delivery tube that can be adjusted to control the rate. With the bolus or syringe method of delivering nutrients into the tube, the formula is measured and then you attach the syringe to the tube. Pour the formula in and then allow the formula to flow via gravity. You never use a plunger to force the formula through the tube. This is quick and simple. With J-tube patients, bolus method is associated with something that's called dumping syndrome, where symptoms of sweating and weakness develop due to the very rapid entry of undigested food into the jejunum. It is often eliminated by having small meals at frequent intervals. Another method of nutrient delivery into the tube is by the gravity drip method. There is a gravity feeding bag, and this is used to administer the formula. The formula is poured into the bag through the opening at the top, and the force of gravity moves the formula through the tube into the stomach. The bags are marked in milliliters for easy measuring, and they come with a roller clamp used to control the flow rate, and that flow rate is set by the physician's orders. All formulas are stored and served at room temperature. The bag must be changed every 24 hours to reduce the rate of bacteria. A meal may last up to an hour depending on the flow rate. It is important to have the client sit upright in a chair, or if in bed, the head of the bed must be elevated at least 30 degrees to reduce the risk of choking or having difficulty breathing. The pump feeding is another method of formula delivery that is controlled by a device that is electric with reserve battery power for transporting a resident or if there is a power outage. The amount of formula to be delivered is determined by the doctor and adjusted according to the device's controls. This method is used for J-tube feeding tube connections to move the food through the tube, which sometimes falls below the patient's center of gravity, and ensures that it makes it into the small intestine. The amount to be administered and the duration of the feeding again is established by the physician's order. Feeding pumps come in a variety of sizes. Some are small enough to fit into the hand and carry in a discreet little pack. We call this an ambulatory pump. And then there are larger models which are mostly attached to an IV pole, which would be a stationary pump. There are some people who administer their own feedings in the home setting. I'd like you to be mindful that a patient may feel discomfort with the initial placement of a feeding tube, regardless of the type or the method used. This is due to irritation caused by the tube, as well as the healing process that the body will go through when an incision is made for the tube. Feeding tubes are not always a permanent part of a patient's care. They may be used for short periods of time and removed when proper nutrition can be ensured without the use of a feeding tube. Feeding tubes may be used for short or long term depending not only upon the needs of the resident, but also by his or her advanced directives. More people now, as they're getting toward end of life or their time is shortened, choose not to have a feeding tube inserted. Feeding tubes can become clogged if not flushed with water after every feeding. The physician will determine the amount of water to be flushed depending upon the client's needs. A clogged tube may simply need to be replaced. An alternative to replacing the tube, depending upon your facility policy or physician order, may be to try to break up the clog, sometimes flushing with warm water, or putting a cola beverage into the tube. A meat tenderizer can break up a clog. And then there is a declogger brush, and using the right size, that is inserted into the tube to try to break up the clog. I want to emphasize that you are not to attempt or do this procedure without specific training from your nurse, without the support of policy in your facility, or a physician's order. The overall effectiveness of enteral or tube feeding varies with the underlying disease, which necessitates the tube feeding. Ethical considerations need to be taken under advisement with end-of-life residents, as I mentioned a couple slides ago. I learned something in nursing school which I have never forgotten, and the saying is, it's easier to withhold than to withdraw. So not to initiate a feeding tube might be the better choice than putting it in and then having the gut-wrenching decision, should we pull the tube? I want to caution you that feeding tubes should only be placed, adjusted, or removed by licensed and trained doctors or nurses. Pulling on the tube, squeezing, or trying to adjust a feeding tube by the patient or a non-trained individual can cause a number of problems and risks. There can be damage or tears to one's internal organs near the entrance point and an increased risk of infection. Next, I'm going to talk about how to care for the incision site. This insertion site is called a stoma, and it needs to be cleaned daily. So let's go through the steps. As always, we provide privacy and explain what we're going to do. Wash hands and apply gloves. If there is any old dressing around the site, you want to remove that and discard it. And always be alert for signs of any irritation, redness, any swelling, or any leakage around the tube. You will need to have available some gauze squares, and then I want you to saturate those with normal saline solution. You cleanse around the exit site of the tube. And then if there is an external bumper, and that bumper is used so that the tube stays in place, if that's present, you want to rotate that slightly so you can clean in all the area around the stoma. This is to prevent skin irritation and any ulceration that might develop beneath the bumper. And then dry the site very well. Oftentimes you can apply a thin layer of protective skin barrier paste or an antibiotic cream if this is ordered by the physician. Place a split dressing over, not under, the external bar if that bar is present. Not all clients will use a barrier paste, so be sure you check the orders and the directions. Secure the dressing with tape if necessary. If this external tube is very long, secure it to the dressing with tape. It just keeps it more manageable. You can mark the dressing with your initials, the date and the time of the care. Now you can remove your gloves and perform hand hygiene. After a week, you want to cleanse the site with soap, water, and leave it open to the air, or according to the physician's orders. Just because a client has a tube into the stomach for feeding doesn't mean that he can neglect his oral and nasal care. Clients who are unable to ingest food or take fluids by mouth should receive regular oral and nasal hygiene to keep the mucous membranes moist and to help prevent infection of the parotid glands. The parotid glands are one of the salivary glands of the mouth, and the secretions from the parotid glands help to lubricate food and make it easier to chew and swallow. Good nasal hygiene will help prevent bacteria from colonizing in the upper respiratory tract. Oral hygiene also reduces the risk of aspiration pneumonia, as it decreases the number of pathogens in the oral and the nasal secretions. I've talked about the bolus syringe method of getting nutrients through the tube, the gravity flow method, and the feeding pump. Now a little bit more about a feeding pump. This is the most common way to administer an enteral feeding. You cannot over or underfeed when this pump is correctly set. There's a reduced risk of the dumping syndrome, which is very unpleasant and uncomfortable for a client. There are warning alarms if there's any malfunction with the machine. And each pump system comes with a feeding set of equipment and attachments to use in administering the formula. There's an ice pouch, tubing, bag to hold a formula, a flush set, and more. Each client you care for will have special considerations around his or her tube feeding. There may be different equipment, different formula, a different care of the insertion site, and different physicians' orders. There may be variation between the facilities. Some may use bags that they fill with formula that comes in cans, and others have a closed system where they spike the container. Before a tube feeding is initiated, it's important to be sure that the tube is in the right location. So you must know your facility's policy regarding the frequency for checking the placement of the gastric tube. Also, know your facility's policy or the physician's order regarding checking for the gastric residual prior to initiating a feeding. In order to check for a gastric residual might read something like, for more than 75 cc's of stomach contents, hold the feeding times 1 hour and then recheck. You must always replace the gastric contents that are drawn out to check for placement. You want to be aware of a resident's medications. A drug such as Dilantin may need to be administered between enteral feedings, not simultaneously. Check the physician's order. Always observe for diarrhea with change in formula or an increase in the amount that's being provided. You may need a different formula or formula with fiber. These are the steps now to be performed when you're providing an enteral feeding. You check the orders for the type, the amount, and the frequency of the feeding. You want to wipe the unopened formula container top with a swab to clean it. You pour the prescribed amount of formula into the container. Cover, date, and refrigerate any remaining formula. Perform your hand hygiene and put on your gloves. The procedure is to take a marker, a permanent marker, and put a check mark on the tube at the exit site, so you can tell if the tube has moved. If the person is in bed, you want to elevate the head of the bed at least 30 to 45 degrees. And if a person is sitting in a chair, assist to a comfortable upright position. Place a towel under the work area. Pour the prescribed amount of formula into the feeding bag. You want to seal or cap the top and then hang the bag on the pole or what you're using to attach it to. Or you can attach a pre-measured formula bag to a pole. Please follow the manufacturer's instructions for threading the formula tubing through the pump and attaching to the client's tubing. Follow the instructions for setting the pump infusion rate. And follow further instructions from your RN on the pump's operation and safety precautions. I want to say again that this module provides basic information and training on the principles of tube feeding. Your nurse will provide specific instructions that you will need for each client that you serve. Thank you so much for your time and attention. I know this was a long, rather technical module. I hope it'll be helpful if you are caring for people who need a tube feeding. When you are ready, please take the assessment. Your skills demonstration will be scheduled with your nurse. Thank you again and wishing you the best.